Hi, my name is Stephanie Gourdeau, and I'm a PGY3 here at McGill University in the CCF-PEM program. And today I'll be talking about aortic dissection detection, risk score plus D-dimer. So acute aortic syndromes, which I'll further refer to as AAS, are deadly cardiovascular emergencies involving the aorta. They include acute aortic dissection, intramural aortic hematoma, penetrating aortic ulcers, and aortic rupture. These diagnostic entities are relatively rare, and they occur in about 4 to 6 cases per 100,000 individuals per year. Acute aortic syndromes are highly litigated diseases with accusations of malpractice against treating physicians and hospitals. Unfortunately, they represent a diagnostic challenge in the ED as patients present with very nonspecific and frequently encountered symptoms such as chest pain, back pain, abdominal pain, and syncope. Hence, the differential diagnosis is very wide and can include acute aortic syndrome, pulmonary embolism, musculoskeletal pain, and gastrointestinal disease. Acute aortic syndromes have a high misdiagnosis rate. Up to 39% of acute aortic syndromes are misdiagnosed. And many physicians do not consider acute aortic syndrome in their initial differential diagnosis. Studies have shown that up to 25% of patients with acute aortic syndrome are not diagnosed with the condition until 24 hours after presenting to the emergency department. Diagnosis of acute aortic syndrome requires either chest and abdomen computed tomography angiography, CTA, or transesophageal echography, TEE. You could also use aortic magnetic resonance angiography, surgery, or autopsy in the worst cases. Realistically, these diagnostic tests cannot be performed in all patients with acute aortic syndrome compatible symptoms. For example, we can't be doing a CTA in every patient presenting with chest pain, as this would be associated with increased healthcare costs, increased contrast-associated complications, increased length of stay in the emergency department, increased incidental findings requiring further follow-up or imaging, and increased stress or anxiety for the patient. In addition, CTA demonstrates very low diagnostic efficiency, with as low as 2% of CTA examinations ordered to rule out acute aortic syndrome turning out positive in North American series. Therefore, a scoring system allowing physicians to reliably rule out acute aortic syndrome using bedside information and a readily available biomarker would be extremely useful in the emergency department, as we do with pulmonary embolism, for example. So the aortic dissection detection risk score, which I will further refer to as the ADDRS, is a tool allowing standardized assessment of the pretest probability of acute aortic syndrome. D-dimer is a well-established rule-out biomarker for pulmonary embolism, and several studies have shown its high sensitivity for acute aortic syndrome also. Because only very few cases of acute aortic syndrome are depicted to occur in patients at low pretest probability on the ADDRS score and also testing negative for D-dimer, the combined use of the ADDRS and D-dimer testing has been suggested as a safe, cost-effective rule-out strategy for acute aortic syndrome with the potential to avoid misdiagnosis and overtesting. This rule-out strategy is currently being externally validated as a potential tool to allow safe rule-out without proceeding to conclusive imaging in low-risk patients. So pending the external validation process currently underway, the goal of this presentation is to review some of the history and the evidence behind the use of this scoring strategy. So in 2010, Paulo Bima and his colleagues published a systematic review of studies evaluating the integration of the ADDRS with D-dimer in academic emergency medicine. Among the multiple studies that addressed ADDRS and D-dimer in acute aortic syndrome, only 4 studies actually met the inclusion criteria in assessing the diagnostic accuracy of the combination of these two strategies, the ADDRS and D-dimer, for the diagnosis of acute aortic syndrome. And the systematic review demonstrated that the integration of an ADDRS score of 0 or 1 and less with a D-dimer of less than 500 showed negligible heterogeneity and consistently high sensitivity across the studies, thus supporting the diagnostic rule-out of acute aortic syndrome. Among the 4 studies included, the study by Nazarian and his colleagues in 2018 was the only prospective multi-center study. It was also the largest among all 4 studies included. For this reason, I decided to focus my talk on the review of this trial, the advised trial by Nazarian, published in 2018. And in addition, I wanted to review a bit some of the literature that led to the development, well, the initial development of the ADDRS and D-dimer rollout strategy. So it all started in 2010 when the American College of Cardiology Foundation, the ACCF, and the American Heart Association, in collaboration with other associations, released the following guidelines for the diagnosis and management of patients with thoracic aortic disease. These guidelines included an aortic dissection pathway. So they proposed 4 steps. The first step was to identify patients in whom aortic dissection needed to be ruled out. So this included patients presenting with chest pain, back pain, abdominal pain, syncope, or symptoms of a perfusion deficit. Once these patients were identified, the second step was to apply the bedside risk assessment tool, which is basically the ADDRS. And the ADDRS score ranges from 0 to 3, as patients can only get 1 point from each category. And the 3 categories include high-risk predisposing conditions, high-risk pain features, and high-risk exam features. The high-risk predisposing conditions include, and this is what you could see in the second box here. So they include Marfan syndrome, family history of aortic disease, known aortic valve disease, recent aortic manipulation, and known thoracic aortic aneurysm. The high-risk pain features included chest pain, back pain, or abdominal pain, but this pain had to be described as either abrupt in onset, severe in intensity, or ripping or tearing. And the high-risk exam features included evidence of a perfusion deficit, such as a pulse deficit, a systolic BP differential, or a focal neurologic deficit, a murmur of aortic insufficiency that was new or not known to be old and in conjunction with the pain, or hypotension or shock states. The score did not account for patients with multiple points in a given category. And finally, in the third step of the proposed algorithm, they suggested risk-based diagnostic evaluations based on the patient's score. For example, if the patient had scored 0, the diagnostic evaluation that was proposed was a chest X-ray. And in step 4, acute aortic dissection was either identified or exclusion. So here's just a bit of a zoom on the ADDRS. So the bedside risk assessment tool was developed on the basis of an extensive literature review on acute aortic dissection, combined with the collective experience of the writing committee. However, the sensitivity of these markers had not been validated. So in 2011, Rogers and his colleagues validated the sensitivity of the high-risk clinical features suggested by the ADDRS. So what they did is they applied the score retrospectively to the International Registry of Acute Aortic Dissection Database, the IRAD, to determine the percentage of patients who had already diagnosed aortic dissection that would have been identified by the score. Just going to take a sip of water. All right. So among the 2,538 patients with aortic dissection who were enrolled in these IRAD centers from January 1996 to December 2009. They assessed the presenting characteristics of the patients with confirmed aortic dissection to evaluate the sensitivity of the score. So of all the patients with aortic dissection included in this study, they found that 28.1% presented with high-risk conditions. The majority, 87.5%, presented with high-risk pain features, and half of the patients with confirmed aortic dissection presented with high-risk exam features. So 4.3% of the patients with aortic dissection scored 0 on the ADDRS score. And of these patients, when they proceeded with to see if they had normal or abnormal chest x-rays, they found that only half of these patients scoring 0 with confirmed aortic dissection had a widened mediastinum. So the study demonstrated that the ADDRS sensitivity, though it was 95.7%, which seems to be a good number, was not sufficient, as 4.3% of patients with aortic dissection would have not been identified. So it did not prove to be a sensitive enough rule-out strategy for aortic dissection, which is a very deadly cardiovascular disease, so you don't want to miss any patients. Many studies then followed on the application of the ADDRS score, and some were done in a more prospective observational fashion. However, these studies persistently demonstrated that an ADDRS score of 0 did not accurately exclude aortic dissection. And this is just one example of some of the studies that were done. In the meantime, the diagnostic performance of D-dimer in a population with aortic dissection was being evaluated. For example, Toru Suzuki and his colleagues published in the journal 2009 a prospective study enrolling only 220 patients suspected of having aortic dissection. And they found that using a cutoff of 500 nanograms per milliliter within 24 hours of the patient's presentation demonstrated a sensitivity of 96.6% and a negative predictive value of 97.6%. Larger systematic reviews and meta-analyses were also performed on the same topic with regards to the use of D-dimer assay in ruling out acute aortic syndrome, such as this one published by Watanabe and his colleagues in Scientific Reports in 2016. And once again, so high sensitivity, high negative predictive values were demonstrated, but the potential to overlook acute aortic syndrome remained when used in isolation. Also, D-dimer offered no discrimination with other entities that could elevate D-dimer and present in a similar fashion, such as myocardial infarction and pulmonary embolism. So this finally brings us to the advised trial, the one I want to focus on mostly today. So the diagnostic accuracy of the aortic dissection detection risk score plus D-dimer for acute aortic syndromes. This study was done by Nazarian and his colleagues in 2018. It was published in the journal Circulation. It was the first multi-center prospective trial evaluating the combined use of ADDRS and D-dimer testing to safely rule out acute aortic syndrome without conclusive imaging. So it was, as mentioned, multi-center, multinational, prospective, diagnostic accuracy observational study. It involved 6 hospitals and 150 physicians in 4 countries, being the UK, Switzerland, Germany, and Italy. And patients were consecutively recruited from 2014 to 2016. The inclusion criteria were the following. You had to be 18 years old and above. You had to experience one or more of the following symptoms, being chest pain, abdominal pain, back pain, syncope, or symptoms of a perfusion deficit. And the need to rule out acute aortic syndrome was determined by the physician. The exclusion criteria were trauma and unwillingness to participate. After eligibility assessment, a case report form was completed by the physician documenting pretest probability based on the ADDRS and the D-dimer test result. D-dimer was defined as negative when below 500, and physicians were not blinded to the items for pretest probability assessment and the D-dimer test results. And subsequent diagnostic and clinical decisions were based on the clinician's judgment. CTA, TEE, and MRA were considered as conclusive advanced imaging methods for the diagnosis of acute aortic syndrome. Patients who were not subjective to these tests, because as mentioned, it was the physicians who determined who needed subsequent imaging and testing. So if you didn't receive any conclusive advanced imaging or surgery or autopsy confirming acute aortic syndrome, the patients entered a 14-day clinical follow-up for case adjudication. Case adjudication, where they decide if the patient has acute aortic syndrome or not, was performed by 2 expert physicians who independently reviewed the diagnostic data and were blinded to the ADDRS and D-dimer test results. The primary outcome was to determine the failure rate of 2 diagnostic strategies to rule out acute aortic syndrome. The first strategy was more conservative, using a ADDRS score of 0 and a negative D-dimer. The second strategy had a slightly higher threshold, using a ADDRS score of 1 and below and a negative D-dimer. And the failure rate represented the number of patients who were deemed low risk using either rule out strategies, but actually turned out to have acute aortic syndrome. The secondary outcome of this study was to evaluate the efficiency of these rule-out strategies. This was calculated by looking at the proportion of patients that would have been considered low risk using either rule-out strategy compared to all the patients that had been screened, because this basically demonstrates that patients that were judged to be low risk with the rule-out strategy would not go on to receive conclusive imaging, as no further follow-up would in theory be required. This is the study flowchart that I'll break down to review the results of the study. Of the 1,930 patients that were assessed for eligibility, 1,850 were included in the study, as 80 patients were excluded for, case report not being completed, age below 18, inadequate for follow-up, or D-dimer not assayed. And among the 1,850 patients that were included, 23.7% scored 0, 57.9% scored 1, 81.6% scored 1 or less, and 18.4% scored above 1. D-dimer was positive in a total number of 813 patients, representing 43.9% of all patients included in the study. 32.9% of the patients scoring 0 had a positive D-dimer. 41.2% of the patients scoring 1 had an ADDRS score and a positive D-dimer. 66.9% of patients scoring more than 1 had a positive D-dimer. This flowchart summarizes the diagnostic workup because, as mentioned in the methods, it's the physicians who determine the need for conclusive imaging at the initial index emergency department visit. So consequently, among the 1,850 patients included in the study, 45.1% got conclusive imaging at the initial index visit, and 54.9% did not get conclusive imaging at the initial visit, but entered the 14-day follow-up period. And among the 1,050 patients that were not initially imaged, that we could see in the right branch, 30 ended up getting conclusive imaging during the follow-up period. Finally, acute aortic syndrome was diagnosed in 13% of the patients, which represented 241 patients. Most of them had type A dissection, but there were also cases of type B dissection, intramural hematoma, and penetrating aortic ulcer. Acute aortic syndrome was deemed as absent in 1,607 patients, which represents 86.9% of all the patients included in the study. Alternative diagnoses in order of prevalence included, what's mentioned here. So MSK chest pain, acute coronary syndrome, gastrointestinal disease, syncope, pleuritis, pneumonia, pericarditis, and more. The ADDRS classification of the patients with acute aortic syndrome. So 5% scored 0, 39.8 scored 1, 44.8 were 1 and below, and 55.2 were above 1. In terms of the D-dimer results, the median D-dimer level in patients with acute aortic syndrome was 5,810 nanograms per milliliter. And this was along an interval ranging from 596 to 50,983. And the median D-dimer level in patients with an alternative diagnosis was 370, with an interval going from 98 to 5,560. These results were deemed to be statistically significant with a p-value of less than 0.001, but the very wide overlapping confidence interval seems non-discriminatory. However, one could extrapolate that maybe very high levels of D-dimer, going up to 50,000, may be observed in acute aortic syndrome more than in alternative diagnoses. As demonstrated in studies that had been done previously evaluating the performance of D-dimer for acute aortic syndrome, a positive D-dimer demonstrated a sensitivity of 96.7%, a negative predictive value of 99.2%, and a good area under the curve of 0.9. This table shows the clinical details of patients with AAS that actually tested negative for D-dimer. So there were 8 patients, and these were the characteristics of these patients. And what seems to be reassuring in 7 out of 8 patients is that patients either had a high pre-test probability score of 2, or demonstrated a widened mediastinum on chest X-ray. However, there is one patient who maybe would have fallen through the cracks. So going back to what the primary outcome of this study was, is they wanted to assess the failure rate of both rule-out strategies, the first strategy being a little more conservative than the second. What they found is that both rule-out strategies demonstrated a failure rate of 0.3%, corresponding to one miscased case in every 300 cases, which does seem quite encouraging. Interestingly, if you had a score above 1 and a negative D-dimer, the failure rate was 4.4%, corresponding to one miscased in every 22 cases. So certainly not a strategy to use, if your pretest probability is already high. The secondary outcome was to determine the efficiency rate of these diagnostic strategies, as patients classified as low risk would not require further imaging. So the first, more conservative strategy demonstrated a low efficiency of 15.9%, meaning that only 15.9% of all the patients you screen using this rule-out strategy will fit into your low risk category and require no further imaging. The remaining 84.1% will need, more of a workup. However, the second rule-out strategy using a slightly higher threshold did demonstrate a higher efficiency of almost 50%. And as we saw, the failure rate was comparable to the more conservative strategy. So that's encouraging. This table depicts the diagnostic variables of both rule-out strategies. We can appreciate a high sensitivity, a high negative predictive value, and a very low negative likelihood ratio for both rule-out strategies. The high sensitivity in this case tells us that those who actually have acute aortic syndrome will test positive. So that means that they will not meet the rule-out criteria. The high negative predictive value tells us that 99.7% of patients who meet the rule out criteria actually do not have acute aortic syndrome. And the negative likelihood ratio is the fact that the probability of acute aortic syndrome decreases significantly when your rule out criteria are met, and generally a negative likelihood ratio of less than 0.1 represents a large decrease of probability when the test is negative. So despite the encouraging statistic yield of the rule-out strategies that were demonstrated in the study, the advised trial does have some limitations. This was an observational study, so it is limited just from its methodology and the potential for the introduction of bias. As mentioned, it's the physicians who discriminatively determined which patients presenting with chest pain, abdominal pain, syncope, and symptoms of a neurodeficit needed to be ruled out for AAS. And these were the ones who were enrolled in the study. So potentially not all patients presenting with AAS and chest pain were actually enrolled in the study if the physician thought, oh, this for sure is not AAS. The physicians were also not blinded to the ADDRS and D-dimer results, and this could have influenced their determination for the need for further investigation, which can lead to verification bias and affect the sensitivity of the score. Also, not all patients were imaged at the index visit, and only 48.7% of all patients enrolled in the study underwent conclusive diagnostic imaging. However, all patients who were not imaged did undergo a 14-day follow-up period, and given the morbidity and the mortality associated with acute aortic syndrome, most cases were probably, caught during that follow-up period. There were 7 adjudicated cases of acute aortic syndrome during the follow-up period. However, I couldn't find much information on these patients in the study and in the supplemental data that was provided. So it was unclear when and how during their 14-day follow-up period acute aortic syndrome was diagnosed and what their initial ADDRS and D-dimer scores were. But however, just the fact that they weren't imaged initially probably suggests that they were judged to have a low pretest probability on presentation, but finally had acute aortic syndrome. So to sum it all up, when we look at different criteria to assess the performance of the ADDRS and D-dimer rule-out strategy, the rule-out strategy that is proposed is feasible. It requires little resources. The score is simple. There's only 3 categories. We can all use it at the bedside. In terms of efficiency, a higher threshold certainly proves to be more efficient while performing as well in terms of sensitivity, negative predictive value, and negative likelihood ratio. This rule-out strategy is acceptable for both patients and physicians. The gold standard the gold standard being CTA, TE, and MRA is certainly accessible in most bigger hospitals and big cities. However, if you use this rule-out strategy in a more remote area, could this potentially lead to an increased number of patients being transferred for advanced imaging? The statistic yield of the test demonstrates the desired characteristics of a rule-out test. So you do want a high sensitivity to safely rule out this dangerous entity. However, the specificity is low, meaning that patients that are considered high risk with the ADDRS D-dimer strategy don't necessarily have acute aortic syndrome, and there's a high probability of being falsely considered positive. Finally, more studies are needed to determine the cost efficiency of this strategy and its effects on morbidity and mortality. So as mentioned, the score at the moment, the ADDRS and D-dimer score, is not externally validated, which limits its current use in the emergency department. I believe that for now it does provide a good template, but the use of clinical judgment is imperative. One of the major limitations I find of the ADDRS bedside risk assessment tool is that it's a bit too simplified. So you could score from 0 to 1, And patients with 2 points in a given category are probably not appropriate for the algorithm. Also, recent studies, such as this one, have shown that different features have stronger associations with acute aortic syndrome. For example, high-risk exam features such as a pulse deficit, a neurodeficit, and hypotension have a much higher likelihood of AAS compared to high-risk predisposing factors and even pain features. So to guide our practice, instead of using the ADDRS score, you can use the Canadian Clinical Practice Guidelines that were recently published in 2020. These guidelines provide evidence-based recommendations about the diagnostic evaluation of patients suspected with acute aortic syndrome. They propose diagnostic investigations depending on pretest probability. So they also created a score that I'll show you. If you score a 0, they say no further testing. Score 1, do a D-dimer using a cutoff of 500. If your D-dimer is positive, proceed to further imaging. And in patients with high probability, which they consider as a score above 1, you should do CTA right away. So this is just an example of the score that they propose in their algorithm that, as you see, takes into account some of the limitations of the ADDRS score by attributing higher points to clinical features with stronger associations to acute aortic syndrome. So though the score and the algorithm, the guidelines hasn't been externally validated, those of the Canadian Clinical Practice Guidelines, these guidelines are endorsed by stakeholder organizations like the Canadian Association of Emergency Physicians, the Canadian Society of Cardiac Surgery, the Canadian Society of Vascular Surgery, and more. So this means that basing and guiding your practice on these guidelines will cover you medical legally. So I strongly recommend that everyone goes through them. And, in the future, I think we should be on the lookout for the results of the external validation process of the ADDRS D-dimer rule out strategy. There are more and more studies that are also exploring the use of a age-adjusted D-dimer levels in combination with the ADDRS. And it'll be interesting to see if maybe POCUS is integrated to some bedside risk assessment tools in the future. So that's it. Thank you.